basically it is different from the traditional, the algorithm models which are available is that the normal models, they generally give a they just give you a linear correlation between the different parameters. Whereas the machine learning does the non-linear correlation as well as the interparameter, the correlation. But that is how, and with the different iteration of these 4 layers, you finally get the results. And coming to the results, you can see the AUC, the accuracy score is almost to the tune of 0.85%. So this is the basic difference between the existing models and our model. The existing models are giving you an accuracy of between 35 to 40%, whereas this present model uses score of
shown. You need to get to the right screen. Your email is being shown on the screen here.
Sorry. So basically the score is 0.89% with our present model.
Yeah, now it's correct. Please go ahead.
Okay, so basically this is the DNN model, and which the accuracy scores are to the tune of between 0.85 to 0.92. So basically that's what I was telling, that the difference between the other models and our model is the accuracies are almost double of the existing scores which are presently available last time. And finally, let me tell you, this is how the report comes to. The report is handed over to the patient, and where you can see the patient score versus the optimal score. Again, it has been brought up by the machine learning itself, that what could be the optimal score for that particular person, for that age and that sex, and then what is the patient's current score. So patient can know where he stands, whether he's better or he's in a bad shape. And also, this is the first time it gives you the 3 modifiable risk factors which can be worked upon. Like here again, you can see for this particular patient, the diastolic blood pressure, dyslipidemia, and smoking. These were the 3 modifiable risk factors which came out, and the physician can start working on that, probably putting on the medication and changing the lifestyle and other things. And again, a person can take the score after 6 months, and we can see what happens to his score, whether the score has gone up or gone down. So it also gives you an indication, not a snapshot at one particular time what is your risk, but over a period of time what is happening to your risk, whether it is increasing or decreasing, and your lifestyle changes are they helping it or not. With this, I would like to end my talk here and then back to Dr. Sridhar.
Thank you, sir. I would just like to go through a very quick video. Saurabh, if you can just play the video, which shows the stream of how this is being done. So we have this web app at the moment where you can go in and log. It talks about why the AICDP is different. This is something which the clinicians are going to use. We are also talking here about the interpretation and the adoption message. We talk about the research that we have done, and then we provide the login and password for the doctors to go in and then enter the patient's name. You can also see in the left-hand side, there is a user manual which will tell how to use this when they require. So now that we are entering all the data about the patient, his location, his email, his phone numbers and all, we would then move on to have a patient's consent. We also provide the patient about the information of how this clinic is all about. So you can see a very detailed consent form is there for the particular patient. And then the doctor would take the consent and move into the next set of area where the data can be entered. So we move with height, weight, heart rate, systolic blood pressure, diastolic blood pressure, respiration rate, pulse rhythm. So these are all of the 21 risk factors. As you can see, if you have any problems with the definition of each one of them, you can go and put your cursor over the place and understand what it actually means and what data that you have to enter. Once we've done all of these, we have a chance to have a conversation with the patient, understand how the data has been captured, and then we go about in generating the risk score. As Sir just said, in the output we get the risk category, the patient score, the optimal score, top modifier, the risk factor, and then on the right-hand side, if you focus, we get the recommended protocol, which talks about what the patient needs to do next. And then we come out with a full report for the patient, which he can take home and keep it in his record. With this, I'll ask Saurabh to stop here. Thank you, Saurabh, for putting this video. At this time, I have the privilege to actually invite Professor Rishi Sethi from King George Medical University in Lucknow. Rishi sir, you have been instrumental in validating this particular tool, particularly in younger population below 40 years in Lucknow. Could you share your experience in a very short
Well, very, very good afternoon, everyone. And it's really a pleasure to meet all of you online. So, we got introduced rather infected with the contagiousness of Dr. Shiv Kumar and Sujoy on this matter. And slowly and slowly it has grown over us. There are multiple projects that we are running together. One that we have completed, another that is in the pipeline that would be, prospectively studying all those patients who have not had an acute coronary syndrome till now, taking our medicines fully into confidence also. That's a longer project, but one of the projects that we have completed is that we have tried to, there was a problem, and the problem statement was that a lot of Indian patients were coming to our hospitals with ST segment elevation MIs and acute coronary syndrome who did not have traditional risk factors for CAD and were younger in age group. And that is a confounding, sort of a patient set that we all encounter. So we tried to study that in younger patients of acute coronary syndrome, that is patients that are less than 40 years, and they were constituting around 10 to 15% of our admission, and that was unfortunate. So we applied various already existing clinical risk scores and compared them how AICVD risk scores compared to those patients who were less than 40, and most commonly these patients have lesser amount of risk factors also. So the concept was that, of course, it was not a prospective study in asymptomatic patients. These patients already had an episode of acute coronary syndrome, but the hypothesis we were studying was that had AICVD being applied to these patients one day before occurrence of acute coronary syndrome, what were its chances of picking up high risk and moderate to high risk individuals as compared to other conventional risk scores? So this was a pretty interesting study where we understood anything. I'll just share, I don't have any slides, but if you can allow, I'll just share my one graph which will explain what our results were. Sujoy, if you can allow me to share my screen. Yeah, it's been disabled from my end.
Moderator, please give sharing capability to Dr. Sethi. Dr. Sethi, give us a minute.
Sure. Yeah, sure. So this is one of the slides from this paper, and I go screen mode here. So what we saw was that we studied 4 risk factors: Framingham, WHO, and QRS scores, which were already available and applied in our university, applied across various patient population, and we compared it to the blue bar, the purple bar of the AICVD risk score. Now we see here that these are patients who are less than 40 years of age. So had these risk factors, traditional risk scoring systems, being applied to these patients one day prior to the occurrence of the ACS, it was the AICVD which would have picked up the risk moderate to severe degree. 39%, 40% were moderate risk in these particular subgroup, and 23% were high risk. So nearly about 63% of this patient population would have been classified as a moderate to high risk CVD population, and maybe preventive strategies, that's a hypothesis, maybe preventive strategies in them would have prevented the occurrence of this ACS. As compared to the blue, red, and the green bars of the Framingham, QRS, and the WHO risk scores, most of these patients would have been classified as low risk, and probably preventive strategies would not have been put into place in this particular patient. Now, this is an interesting hypothesis, although I would say that scientifically it's not the best way to look at it because it's again a retrospective study where we are hypothesizing. But then it is a very, very strong support of this hypothesis has come, and a prospective study in a larger patient subset would probably answer this question and establish the role conclusively of AICVD and its superiority to the other conventional risk scoring system. So this was around 350 patients, and these were just all acute coronary syndrome patients for the purpose of scientific publication. So Jay made a very interesting observation around 1 year back that we need to have a control group. Now we have a 350 patient data set in which the event had happened, and we have around 1,300 patient subgroup for control, and we are on the way to a great paper and a great publication if everything goes well. So I thank you for your attention. This is everything I'm happy to.
Thank you very much for your time. I would quickly move to Dr. Karen.
So Joy, may I intervene for a minute, Dr. Sethi, because I'm a layperson like many of the media, and therefore may I request you to please clarify that point. What I understood is the score is enabling people who would have normally been classified by other risk scores as moderate or low risk, because the AICVD takes in more factors and understands the Indian population. It is better at picking up high-risk patients. Is that interpretation correct, and could you please validate that?
Yes, that's correct. And for the benefit of my media friends, we have to understand that when we talk about risk scoring systems for cardiovascular disease, the real benefit is how do we pick up those individuals within the society or from within our outpatients follow-up for hypertension and diabetes. How do we pick up those patients who are at higher risk of having acute coronary syndrome, which are myocardial infarctions or heart attacks that we know in general language. So if we can predict those individuals that are at high risk to having these acute coronary syndromes and myocardial infarction, then we can put more aggressive preventive strategies into action, and then we can probably prevent heart attacks or ST segment elevation MIs or acute coronary syndrome from taking place. Now, we have seen in our study that if in this population, let's say young patients who are less than 40 years of age, who were traditionally not supposed to have an acute coronary syndrome by any common wisdom, they had presented with heart attacks, and had we used AICVD risk scores when they, previous to heart attack, we may have picked up these patients as high-risk patients, while other conventional risk scores, which cardiologists and medicine world use in general right now, probably would not have picked up high-risk nature of these patients. So it is something very, very important, because we have, as ma'am was saying, that our hypothesis is, and our assumption is, that if we use the AICVD risk scoring system in these patients, we will pick up in Indian subset more patients who are likelihood to have acute coronary syndromes in future, and then putting up preventive strategies of controlling hypertension, diabetes, dyslipidemia, smoking, stress. Everything can be put into place, and we can prevent heart attacks, because once heart attack and acute coronary syndrome happen, then probably half the battle is already lost. So the whole trick is to predict those patients who are going to have ACS and then put preventive strategy, and in that scenario, we believe that AICVD risk scores over other traditional scoring systems that have already existed.
I would just add one line to that. It's absolutely right, because the traditional risk factors have been given the weightage too much to the age. And that is the reason those who were elderly people, they always had a high risk compared to the lower risk, the lower age people below 40. So AICVD becomes really relevant, because India is supposed to be a young country because of most of the young people. So it becomes much more relevant to apply on our population and get better results, and probably we can identify the moderate and high risk population at a very early stage and do the prevention. Sorry.
Thank you, sir. I am inclined to now bring in Dr. Karen Priyadarshini, who is the healthcare industry lead at Microsoft Bank in India. Dr. Karen, all yours.
Yeah.
You could just highlight on the board.
Yeah, thanks so much, Dr. Sujoy, and nice to see Dr. Reddy and Sangita. Hi, very kind of you to give me this slot. probably would take about 3 to 5 minutes to share my views on this. I totally agree with what both the doctors earlier shared. I don't know if many of you have seen the report yesterday from NHS, which said that more than COVID, the thing that killed a lot of people was heart disease. And I think this becomes very important, and this is so timely because I think just 2 weeks ago we lost one of our colleagues. He lost his child at a very young age. So we see that these risk factors are increasing at a much lower population, and I think this is where the cardiac risk score becomes very important because you're adjusting the weight of the wearable on the age, you're kind of making it more equitable. But one of the things in my role, what I've always done is I've shared this cardiac risk score that Apollo has so beautifully built across multiple markets. And one of the things that beautifully stands out is that if you look at all the other scores that are present, the Framingham score is very widely used in this part of the world. One of the key differentiating parameters is inclusion of local parameters. So for example, chewing of tobacco. I mean, normally you will never find that in any score, but this is very common in India and very common in Malaysia. So inclusion of variables which are akin to the local country, it becomes very important. And I think this is where this particular cardiac risk score developed by Apollo really scores very well, because it is built for a particular set of population who have those risk factors. And I think that is why you see that automatically the success is much better than most of the standard scores. And given the fact that I would actually go a step further. Of course, the model is now being validated based on the people who already have, let's say, cardiac problems. But I would take the step forward would be to include it in the last mile action. One of the things that really kind of hit me was that you really don't have to come back and do a whole cardiac assessment. While you're doing your, let's say, health screen,